Inflammation classically describes four key signs, each of which have a Latin derivation: calor or heat, dolor or pain, rubor or redness, and tumor or swelling. Sometimes these four signs combine to cause a fifth sign, which is functio lysa, or temporary loss of function due to pain or swelling. Alright, so inflammation usually starts with some stimuli, like a pathogen. Now, even though pathogens are a common cause of infection which can lead to inflammation, inflammation can be caused by other things as well, like toxins and trauma. For example, after an intense workout, your muscles might feel sore. That's due to inflammation trying to repair your overused muscle fibers. Ultimately, the goal of inflammation is to respond to the stimuli and restore balance. Oftentimes, that includes eliminating the cause of tissue injury, clearing out necrotic or dead cells, and starting tissue repair. Broadly speaking, inflammation can be triggered by external and internal factors. External factors can be non-microbial or microbial. Non-microbial factors include allergens, irritants, and toxic compounds. Now, the two main microbial factors that trigger inflammation are virulence factors and pathogen-associated molecular patterns, or PAMPs. Virulence factors are molecules that help pathogens colonize tissues and cause infection. PAMPs are small molecules with conserved patterns that are shared across many different pathogens, including bacterial wall components like peptidoglycan, lipopolysaccharide or LPS, and lipoteichoic acid, and fungal wall components like mannan. For intracellular pathogens like viruses, PAMPs might include the viral RNA or DNA. Our immune system recognizes virulence factors and PAMPs as foreign substances, and can trigger an inflammatory response against them. Now, in terms of internal factors, it turns out that there's an endogenous equivalent to PAMPs called damage-associated molecular patterns, or DAMPs. DAMPs are intracellular proteins that get released when a cell's plasma membrane is injured, or when a cell dies. So DAMPs are a signal that there's serious cell damage, and they trigger inflammation. Now, PAMPs and DAMPs are recognized by pattern recognition receptors, or PRRs, which are cell surface receptors on various leukocytes that help to activate those cells and spark the inflammatory response, which can be thought of as the innate immune system. Key features are that this response is nonspecific, meaning that PRRs don't distinguish one specific pathogen from another, although they can distinguish between broad categories like viruses from bacteria. Also, the response is super fast, occurring within minutes to hours. And finally, there's no memory associated with innate responses. Generally speaking, there are two main types of leukocytes: granulocytes, which include neutrophils, eosinophils, basophils, and mast cells, and agranulocytes, which include lymphocytes and monocytes, which can differentiate into macrophages or dendritic cells. The inflammatory process usually starts with either macrophages or mast cells, both of which are found in the tissues. When there's tissue damage, these cells respond to the PAMPs or DAMPs. Mast cells have granules containing different inflammatory mediators, like histamine, serotonin, cytokines, and eicosanoids, like prostaglandins and leukotrienes. These inflammatory mediators act on the endothelial cells surrounding the capillaries nearby, causing them to separate from each other. In addition, macrophages, which are the garbage truck of the body, start to eat up invading pathogens. The release of cytokines causes capillaries to get larger and increase vascular permeability, allowing plasma proteins and fluids to leave the circulation. Endothelial cells also help spur on this process by releasing nitric oxide, which helps vasodilate the capillaries and makes them more permeable. In addition, endothelial cells express more adhesion proteins to help leukocytes that are floating by in the blood to attach and roll along the vessel wall until they reach the injured site. In particular, neutrophils get attracted to the site of infection by the chemokines and microbial products. The neutrophil then starts to squeeze through the gaps between two endothelial cells until it reaches the other side, and this is called extravasation. It's kind of like squeezing between two fence poles to sneak into an amusement park, rather than paying admission. But that's not to say you should do that. Now, next, the leukocyte follows a gradient of inflammatory mediators to get to the site of inflammation. Neutrophils are the first leukocytes recruited during the acute inflammatory process, and they're like hungry athletes. They immediately start phagocytosing or eating pathogens in damaged cells. Neutrophils take in a lot of pathogens quickly, kind of like a vacuum, and then commit suicide, destroying themselves and all of the pathogens they've taken in. Now, while this is all happening, there's also a family of soluble proteins called the complement system. The complement proteins most often get activated in the presence of antibodies bound to pathogens, or by molecules on the pathogens. Once these complement proteins are active, they help attract leukocytes, and help with opsonization, meaning that they can bind to microbes so that leukocytes can more easily phagocytose them. Kind of like sticking a fork in a meatball so that it doesn't slip away. Some of the complement proteins also kill pathogens by directly forming a channel in their membrane, literally punching a hole in it. All the while, dendritic cells continue to phagocytose pathogens and present bits of them to T lymphocytes. This activates the adaptive immune system, which kicks in after a few days. If the stimulus for all of this inflammation was a cut or a scrape, then platelets and clotting factors from the plasma reach the area and clot the wound. This helps stop the bleeding, as well as prevents pathogens from entering the bloodstream, and provides a framework for tissue repair. In summary, all of these factors contribute to the heat, pain, redness, and swelling that's classic for inflammation. Now, the inflammatory response ends with tissue repair. Macrophages are recruited to eat up dead and dying cells, so that when tissue can make room for new cells, this is followed by angiogenesis, which is the formation of new blood vessels, and that's triggered by growth factors released by macrophages. These newly formed blood vessels are temporary, meaning that once the wound is healed, these new vessels regress. Finally, there are fibroblasts, which come into the area of inflammation and synthesize collagen to help with wound healing. Overall, if there's only mild damage, then the tissue regenerates back to its normal healthy state. But if there's severe damage, then the damaged cells get replaced by a non-functional fibrous scar. Alright, as a quick recap. Inflammation is a complex response to harmful stimuli, which could be from a pathogen, but it also could be from trauma or toxins. The response involves blood vessels dilating and becoming more permeable, and attracting more immune cells and fluid into the local tissue. The classical signs of inflammation are heat, pain, redness, and swelling, and these can lead to a loss of function. The inflammatory response ends with wound repair and resolution, either restoring the initial tissue integrity or leaving a fibrous scar.
At the ophthalmology clinic, 71-year-old Zoe comes in. She says that about 4 hours ago, she experienced a sudden flash of light followed by many floaters in her right eye. Her visual disturbances have since progressed to a peripheral loss of vision, and it's spreading to the rest of her visual field. Next to her, an 8-month-old male infant named Nurbin is brought in by his father, who is worried because he noticed that Nurbin's eyes appear white in their family pictures. Ophthalmologic examination reveals the absence of red reflex on both eyes. On further questioning, the father tells you that, as a child, he had to have his left eye enucleated, or removed, but he is unsure as to the exact reason why. Based on the initial presentation, both Zoe and Nurbin have some form of retinal disorder. But first, a bit of physiology. If we zoom into the wall of the eye, it is made up of 3 major layers. There's a fibrous outer layer, which contains the cornea and sclera and helps shield excess light. The middle vascular layer is called the uvea and consists of the iris, pupil, choroid, and ciliary body. Finally, the neural layer consists of the retina, with its own outer pigmented layer and an inner neural layer that's composed of photoreceptor cells, which convert light into neural signals that travel via the optic nerve to the brain for visual processing. Okay, let's start with age-related macular degeneration, or ARMD for short. This refers to an acquired degeneration of the macula, which is the central area of the retina. It can be divided into dry or non-exudative ARMD, which accounts for the vast majority of cases, and wet or exudative ARMD. Dry ARMD is characterized by yellowish extracellular deposits of waste materials that build up between the Bruch membrane and the retinal pigment epithelium. For your test, remember that these deposits are often known as drusen. On the other hand, in wet ARMD, there is abnormal neovascularization, meaning that abnormal blood vessels grow from the choroid behind the retina and can leak intravascular fluid or blood. In terms of symptoms, dry ARMD usually presents with gradual vision problems, such as metamorphopsia, which is a type of distortion where linear objects appear curved or discontinuous, as well as scotomas, or missing areas of vision, and eventually it can lead to central vision loss. In contrast, wet ARMD causes rapid central vision loss over a few weeks or months. Ultimately, individuals with ARMD can become legally blind, even though their peripheral vision remains intact. Diagnosis is based on fundoscopy, and treatment focuses on slowing vision loss. For dry ARMD, multivitamin and antioxidant supplements have been shown to help, while wet ARMD can be treated with injections of antivascular endothelial growth factors, or anti-VEGF for short, like bevacizumab or ranibizumab, which inhibit neovascularization. Next, there is diabetic retinopathy, which is retinal damage resulting from long-standing and poorly controlled hyperglycemia in people with diabetes mellitus. It can be broken down into non-proliferative diabetic retinopathy, where damaged capillaries leak blood into the retina, and proliferative, where chronic hypoxia results in neovascularization or the formation of new blood vessels that are fragile and can break, bleeding into and damaging the retina. For your tests, it's important to remember that diabetic retinopathy is usually asymptomatic until late stages, when it causes painless visual impairment that can progress to blindness. Diagnosis is made with fundoscopic examination, which in the case of non-proliferative retinopathy reveals microaneurysms along with the high-yield cotton wool spots, which are fluffy white patches on the retina. Now, in addition to these findings, proliferative retinopathy also shows neovascularization. Treatment of non-proliferative diabetic retinopathy relies on blood glucose control, while proliferative diabetic retinopathy can be managed with anti-VEGF injections, peripheral retinal photocoagulation, or surgery. Bear in mind that both non-proliferative and proliferative diabetic retinopathy can be prevented by keeping blood sugar under control. Similarly, there is hypertensive retinopathy, which refers to retinal damage from chronic uncontrolled hypertension. For your exams, remember that it is associated with an increased risk of stroke, coronary artery disease, and kidney disease. Now, only in late stages, hypertensive retinopathy may present with decreased or blurred vision. Fundoscopic examination may reveal microaneurysms and cotton wool spots. But What's even more characteristic is the macular star, which results from the star-like deposition of exudates into the macula, along with flame-shaped retinal hemorrhages and arteriovenous nicking. This is seen when an arteriole with a thick arteriosclerotic wall compresses a vein that it happens to cross, so this vein bulges on both sides next to the crossing. In severe cases, papilledema or swelling of the optic disc can also be seen. Treatment of hypertensive retinopathy requires immediate and long-term control of blood pressure. Moving on to papilledema, which refers to swelling of the optic disc. This is classically caused either by severe hypertensive retinopathy or by increased intracranial pressure due to a space-occupying lesion, such as tumor or hemorrhage. Symptoms include blurring, flickering, or even complete vision loss. For your exams, remember that in the case of increased intracranial pressure, individuals will often experience nausea and vomiting as well. For diagnosis, fundoscopic examination might reveal an enlarged blind spot and an elevated optic disc with blurred margins. Treatment focuses on managing the primary cause. If a reduction of intracranial pressure is needed, diuretics and antihypertensives are commonly used. Next, retinal vein occlusion refers to the compression of the central retinal vein or one of its branches due to a thrombus, a narrow vein, or from an atherosclerotic artery crossing it. This manifests as an acute monocular vision loss. For diagnosis, look for a history of cardiovascular risk factors, such as diabetes mellitus and hypertension, or hypercoagulable states like polycythemia vera. For diagnosis, fundoscopic examination may reveal optic disc swelling, retinal hemorrhages, and dilated veins that give a characteristic blood and thunder appearance. Edema in affected areas can also be seen. Treatment can include laser photocoagulation and steroid or anti-VEGF injections. Now, don't confuse retinal vein occlusion with central retinal artery occlusion, which also results in acute monocular vision loss. This can be caused by an embolism resulting from atrial fibrillation, cardiac vegetations, or a patent foramen ovale, but might also be due to thrombosis of the retinal artery, usually as a result of atherosclerosis. On fundoscopy, the retina appears cloudy with attenuated vessels and the characteristic cherry red spot in the fovea or center of macula. For your exams, note that this is seen because the macula receives its blood supply from the choroid, which remains unaffected, while the surrounding retina is pale and ischemic due to the retinal artery occlusion. Treatment may include hyperbaric oxygen therapy, which involves the inhalation of 100% oxygen at a pressure that's higher than the atmospheric pressure. The purpose of this is to raise the amount of oxygen delivered to the ischemic retinal tissue. Finally, to prevent further embolism, it's also important to find the embolic source. Next, retinal detachment occurs when the neurosensory layer of the retina is separated from the underlying retinal pigment epithelium, resulting in degeneration of the photoreceptors and, eventually, vision loss. The most frequent causes are retinal breaks, which can be secondary to head trauma, or vitreous degeneration, which is a natural process that occurs with aging, where the vitreous humor changes from being a thick gel to a watery fluid. Significant vitreous degeneration can lead to a posterior vitreous detachment, which, in turn, causes traction on the retina and potentially a retinal tear. The liquefied vitreous can then seep through the tear and under the retina, causing it to detach. Another high-yield fact is that retinal breaks are also much more common in those with high myopia. Less frequently, retinal detachment can occur without any tears. This is typically the result of traction on the newly formed blood vessels in proliferative diabetic retinopathy or inflammatory effusions. The classic exam vignette will present someone with light flashes or floaters described as fine dots, veils, cobwebs, clouds, or strings, followed by sudden visual field loss in the affected eye. This typically begins in the periphery and progresses toward the central visual axis over hours to weeks, like a curtain drawn down. Diagnosis is based on fundoscopic examination, which may visualize crinkling of retinal tissue or changes in blood vessel direction. For your test, remember that retinal detachment is an emergency and requires surgery to restore sensory function. Next is retinitis pigmentosa. This is a hereditary degeneration of the retina that results in painless, progressive vision loss. What's high yield to know is that it starts with night blindness and peripheral vision loss, and in late stages goes on to affect central vision. Retinitis pigmentosa takes its name from the fundoscopic exam showing a pattern of bone spicule-shaped dark spots and blotches that are visible around the macula of the retina. Unfortunately, there is no effective treatment. The last retinal disorder is retinoblastoma. This is a relatively common tumor in childhood caused by the mutation of both alleles of the retinoblastoma or RB1 gene on chromosome 13. Now, retinoblastomas can be hereditary, in which case the individual usually inherits a mutation in one of the alleles of the RB1 gene. If, for some reason, a random mutation occurs in the second allele of the RB1, that leads to the development of retinoblastoma. This is known as the two-hit hypothesis. For your test, keep in mind that hereditary retinoblastomas are typically bilateral and are associated with an increased risk of developing other malignancies like osteosarcoma, soft tissue sarcoma, and malignant melanoma. Another high-yield fact is that an individual with hereditary retinoblastoma has a 50% chance of passing on the mutated allele to their child. Now, there are also sporadic retinoblastomas, which occur when two spontaneous mutations affect both RB1 alleles. For your exams, remember that sporadic retinoblastomas tend to be unilateral. Now, in terms of symptoms, what's especially high yield is that retinoblastoma typically presents with leukocoria or white pupil. So, when flash photography of the person is taken, instead of the red eye effect, they'll have white pupils. This is particularly noticeable for unilateral cases since, in the normal eye, the light will reflect from the fundus and appear red, but the tumor that grows on the fundus will block light, so it appears white. Remember that another cause of leukocoria is congenital cataract. The tumor can also cause eye pain if large enough. Now, if the tumor metastasizes, it can also present with anorexia or lack of appetite, weight loss, vomiting, headaches, or neurologic impairment. Diagnosis of retinoblastoma begins with a red reflex test, which functions similarly to flash photography. Light is directed from an ophthalmoscope through the eye and then reflected back from the retina and appears red. And since the retinoblastoma blocks the light, the red reflex will be absent in the affected eye. This is followed by a fundoscopy examination to confirm the diagnosis of retinoblastoma and to determine its exact location and extent of involvement. Definitive treatment consists of enucleation or complete removal of the eyeball. Alright, as a quick recap, retinal conditions include age-related macular degeneration, which is most often dry or non-exudative, and rarely wet or exudative. Diabetic retinopathy results from long-standing and poorly controlled diabetes mellitus and can be proliferative or non-proliferative. Hypertensive retinopathy results from chronic, uncontrolled hypertension. Papilledema refers to optic disc swelling due to hypertensive retinopathy or increased intracranial pressure. Retinal vein occlusion is associated with a thrombus or an atherosclerotic artery compressing the retinal vein or a branch, while central retinal artery occlusion is due to embolism or atherosclerosis. Retinal detachment is usually due to retinal tears, but can also be caused by diabetic traction or inflammatory effusions and is a surgical emergency. Retinitis pigmentosa is an inherited, progressive retinal degeneration. Finally, retinoblastoma can be hereditary or sporadic and causes leukocoria and absent red reflex. Okay, back to our cases. 71-year-old Zoe came in complaining of an acute case of vision loss that's described as the curtain being drawn down in her right eye. This was preceded by flashes and floaters. This is classic for retinal detachment, which was then confirmed with fundoscopy and treated with surgery in an emergency setting. On the other hand, Nurbin, the 8-month-old infant, presented with bilateral leukocoria. This, along with the absence of red reflex and the possible family history, suggests bilateral hereditary retinoblastoma. Diagnosis was confirmed with fundoscopy and treatment involved enucleation.
At the ophthalmology clinic, 61-year-old Pedro presents with vision impairment that has been progressive over the last couple of years. He denies experiencing any pain. His past medical history is significant for type 2 diabetes mellitus. Physical examination shows bilateral clouding of the lens. Next to him, 68-year-old Eileen comes in. She complains that about an hour ago, she started experiencing excruciating pain in her right eye, accompanied by blurry vision and seeing halos around bright lights. Eileen also tells you that she has since vomited twice. On clinical examination, her right eye is red, with a dilated pupil that fails to react to light. Her left eye appears unremarkable. Based on the initial presentation, both Pedro and Eileen have some form of eye condition. But first, a bit of physiology. If we take a closer look at cross-section of an eye, we can see that it's split into 3 different chambers: anterior, posterior, and vitreous. The anterior chamber includes the area from the cornea to the iris. The posterior chamber is a really narrow space between the iris and the lens. Finally, the much larger vitreous chamber includes the space between the lens and the back of the eye. Now, both the anterior and posterior chambers are located in the anterior segment of the eye, while the vitreous chamber is part of the posterior segment of the eye. Both chambers in the anterior segment, that is, the anterior and posterior chambers, are filled with a clear watery fluid called aqueous humor, while the vitreous chamber is filled with a clear but thicker fluid called the vitreous humor. Okay, let's start with what's probably the most common group of eye conditions, so refractive errors. Normally, when the eye is in a relaxed state, the refractive power of the cornea and lens help focus light into the retina. The retina is like a movie screen, and the distance from the projector is the axial length of the eye. If it's too close or too far from the projector, the image will end up looking blurry or out of focus, when the lens and cornea can focus light perfectly on the retina. It's called emmetropia. In hyperopia, it's also known as farsightedness. The axial length of the eye is too short for the refractive power of the cornea and lens, so light ends up focusing behind the retina. Hyperopia can be corrected with convex or converging lenses. In myopia, also known as nearsightedness, the axial length of the eye is too long for the refractive power of the cornea and lens, so the light focuses in front of the retina. Myopia can be corrected with concave or diverging lenses. In astigmatism, there is an abnormal curvature of the cornea, which results in various refractive power at different axes. Astigmatism can be corrected with cylindrical lenses. Finally, there's presbyopia, where increasing age causes changes in the lens curvature, as well as a decline in the elasticity of the lens, and the strength of the ciliary muscle, which normally controls accommodation of the lens to see objects at different distances. As a result, presbyopia impairs accommodation or focusing on near objects, which can be corrected with magnifying reading glasses. Okay, let's switch gears and discuss cataracts. This refers to clouding or opacification of the lens, and it can be congenital or acquired. The main risk factors for congenital cataract include congenital infections. For your exams, these infections can be remembered with the acronym TORCH, which stands for Toxoplasma, other infectious agents, usually syphilis, rubella, cytomegalovirus, and herpes simplex virus. Other risk factors for congenital cataract include genetic conditions such as trisomies 13, 18, and 21, Marfan syndrome, Alport syndrome, Refsum disease, myotonic dystrophy, neurofibromatosis type 2, and inborn errors of metabolism like galactosemia. For your exam, remember that galactosemia can be type 1, caused by a deficiency in galactose-1-phosphate uridyltransferase, or type 2, which is caused by a deficiency of galactokinase. Type 1 is the more common type, so it's also called classic galactosemia. Here, excess circulating galactose is converted to galactitol by the enzyme aldose reductase. Galactitol then accumulates in the lens, creating a hypertonic environment that pulls in water, results in the swelling of lens fibers until they rupture, and this is called osmotic cellular injury. Now, when it comes to acquired cataract, risk factors include advanced age, usually above 60, smoking, excessive alcohol use, eye trauma and infections, exposure to UV light, prolonged use of medications like glucocorticoids, and diabetes mellitus. For your exams, note that the mechanism behind cataracts in diabetes mellitus is similar to that in galactosemia. So when there's hyperglycemia, the excess circulating glucose is converted to sorbitol by aldose reductase. Sorbitol then accumulates in the lens, causing osmotic cellular injury. Now, the main symptoms of cataract is painless visual impairment that's often bilateral and progresses slowly over many years. For your exams, bear in mind that congenital cataract may also manifest with leukocoria or white pupil, which is an abnormal white reflection from the retina of the eye, also called a white pupillary reflex. Remember that another cause of leukocoria is retinoblastoma. Diagnosis of cataracts include slit lamp examination, which shows loss of lens transparency, and treatment is surgical removal of the lens nucleus. Another high-yield ophthalmologic condition is glaucoma. Normally, the aqueous humor is secreted by the ciliary epithelium into the posterior chamber, then flows through a narrow space between the front of the lens and the back of the iris, and through the pupil to the anterior chamber. From here, the fluid flows out of the eye through the trabecular meshwork, goes down into the circular channel, called the canal of Schlem, and finally into the aqueous veins. A small fraction of the aqueous humor follows the uveoscleral pathway, draining across the uvea and sclera to get reabsorbed by orbital vessels. In glaucoma, part of the trabecular meshwork becomes partially or completely blocked. Now, there are two types of glaucoma, open and closed angle. First, there's open-angle glaucoma, which receives its name from the fact that the angle between the cornea and the iris is open. This is the most common type, especially in Black individuals, as well as those with advanced age or family history. Now, open-angle glaucoma can be primary, in which case the cause is unknown, or secondary to another condition, where the drainage system slowly gets clogged over time. Common causes include a buildup of white blood cells, such as in the case of uveitis, red blood cells, in the case of vitreous hemorrhage, or even retina elements, in the case of retinal detachment. In all cases, there's a gradual increase in the intraocular pressure, or IOP for short. Initially, this results in atrophy of the outer rim of the optic nerve, decreasing the peripheral vision. Over time, as the IOP increases even more, there's continued damage to the optic nerve, eventually leading to a loss in central vision as well. Then there's closed-angle glaucoma, also called angle closure glaucoma or narrow-angle glaucoma, which receives its name from the fact that the angle between the iris and the cornea is narrowed. Again, closed-angle glaucoma can be primary or secondary. In primary cases, for unknown reasons, the lens is enlarged or gets pushed up against the iris. On the other hand, secondary cases are caused by hypoxia from retinal diseases, like diabetes mellitus or central retina vein occlusion. This hypoxia induces neurovascularization or growth of new blood vessels in the iris, which is pushed anteriorly, closing the angle. Another secondary cause of closed-angle glaucoma, common in the elderly, is taking muscarinic blockers, like atropine. These medications can cause mydriasis, or pupil dilation, thus reducing aqueous humor outflow. In both primary and secondary cases, the result is the drainage system gets blocked, just like with open-angle glaucoma. Now closed-angle glaucoma can be acute, in which case the blockage causes a rapid and sharp increase in intraocular pressure, and this is an ophthalmologic emergency. In chronic closed-angle glaucoma, the pressure increase is more gradual and less severe, but will also lead to continued damage to the optic nerve over time. Symptoms of open-angle glaucoma include painless vision loss that progresses from peripheral to central. Chronic closed-angle glaucoma is initially asymptomatic, but can also progress into peripheral to central vision field loss. In contrast, for acute closed-angle glaucoma, you should know that it is a true ophthalmologic emergency that can lead to the abrupt onset of severe eye pain, eye redness, a dilated non-reactive pupil, blurry vision, and seeing halos around lights, as well as frontal headaches, nausea, and vomiting. For the diagnosis of glaucoma, tonometry can be used to assess for increased intraocular pressure. Visual field testing can also be done. Optic nerve damage should be assessed either through imaging or by direct observation. Treatment focuses on medications that decrease the pressure in the eye. This can be done in a couple of ways. First, we can decrease the production of aqueous humor with medication like beta-adrenergic receptor antagonists like timolol and carbonic anhydrase inhibitors like acetazolamide. Next, we can increase the outflow of aqueous humor through the uvascleral pathway with prostaglandin analogs like bimatroprost and latanoprost. Other medications can be used to increase the outflow of aqueous humor through the trabecular meshwork, such as cholinomimetics, like pilocarpine and carbachol, or decrease its production, such as alpha-adrenergic antagonists like epinephrine, apraclonidine, or brimonidine. For your exams, what's absolutely necessary to remember is that in closed-angle glaucoma, alpha agonists are strictly contraindicated, since they can cause mydriasis and reduce aqueous humor outflow even more. Finally, refractory cases of glaucoma can benefit from laser treatment, like trabeculoplasty, in which a laser is used to open the trabecular mesh network, and iridotomy, where a tiny hole is punched in the iris. Alright, as a quick recap, disorders that cause refractive errors include hypermyopia, myopia, astigmatism, and presbyopia, and they can be corrected by wearing the corresponding eyeglasses. Cataracts refers to opacification of the lens and can be congenital, which causes leukocoria, or acquired, which presents with painless, progressive vision loss. Glaucoma is a condition where the aqueous humor flow is blocked and can be open or closed angle, each of which can be primary or secondary. Closed angle glaucoma can be divided into chronic and acute, which is an ophthalmologic emergency. Okay, back to our cases. 61-year-old Pedro presented with painless progressive vision impairment. This complaint, together with the bilateral clouding of the lens, found on physical exam, should make you think of cataracts. Other clues include his age and past medical history of diabetes mellitus, which are risk factors for acquired cataracts. On the other hand, 68-year-old Aileen came in complaining of acute onset of severe right eye pain, blurry vision, and seeing halos around lights. In addition, she has since been vomiting. Along with the physical examination revealing right eye redness and the dilated non-reactive pupil, the diagnosis of acute closed-angle glaucoma is highly likely. This was then confirmed with fundoscopy, which showed increased intraocular pressure, and treated with medications in an emergency setting.
While in the ENT clinic, 2 people present with trouble breathing through the nose and have frequent nosebleeds. One of them is a 25-year-old individual named Andrew, and the other one is an 18-year-old individual named Sarah. Andrew says the problems appeared gradually and feels like something is stuck in the nose. Andrew also has a history of aspirin allergy. On examination, everything seems normal except for a decrease in the sense of smell. Sarah, on the other hand, has noted these problems ever since childhood. Sarah also mentioned that the symptoms get worse during the spring or proximity to flowers. On examination, presentation is nasal congestion and red, itchy, swollen eyes with frequent bouts of sneezing. Blood tests were normal in both individuals. Now, from what we can gather, both have some type of nasal, oral, or pharyngeal disease. But first, a bit of anatomy. The nasopharynx is an open chamber located below the base of the skull and behind the nasal cavity. The nasopharynx contains structures like the adenoids, also known as the pharyngeal tonsils, the Waldeyer's tonsillar ring, which is a ring-like arrangement of lymphoid tissue in both the nasopharynx and oropharynx, the Rosenmuller fossa, which is part of the lateral recess of the nasopharynx and a common site of nasopharyngeal cancers, and the eustachian tube orifices. Now, the nasopharynx connects the nasal cavity and oropharynx, which is posterior to the oral cavity that contains structures like the salivary glands, soft and hard palate, tongue, and tonsils. Okay, so we can begin with nasal polyps. Now, remember that a nasal polyp is a clump of epithelial cells that undergo hyperplasia and form a growth of tissue along the lining of the nasal cavity. This is most often caused by seasonal allergies, recurrent infections, frequent asthma exacerbations, chronic sinusitis, or acetyl salicylic acid and non-steroidal anti-inflammatory drug sensitivity. There are some genetic causes too. That's high yield. Remember that it's associated with cystic fibrosis and primary ciliary dyskinesia. You also need to know that usually, nasal polyps form in the ethmoid or maxillary sinuses and are typically non-cancerous. As polyps enlarge, they often obstruct the airflow as well as the mucus drainage, allowing pathogens to linger in the sinuses and cause recurrent infections. For symptoms, know that this leads to progressive nose breathing difficulties, nose foreign body sensation, the loss of the sense of smell, or anosmia, and bouts of fevers and headaches due to infections. In young infants, it can cause hypoxia, which gives a bluish tinge to their skin color called cyanosis. This specifically happens in infants because they are obligate nose breathers, meaning they really prefer breathing through their nose. If bilateral obstruction occurs, a period of cyanosis occurs, then the infant cries and breathes through the mouth, resolving the cyanosis. So on the exam, look for an infant with periodic bouts of cyanosis resolved by crying. Now, regarding diagnosis, all you need to recall is that nasal endoscopy, or CT, can help diagnose nasal polyps and determine the size, location, and number. The treatment is to shrink them using nasal steroids, which work by decreasing the inflammation and swelling of the polyp. Those unresponsive to steroids are removed by endoscopic sinus surgery. Next, let's look at rhinitis, which is irritation and inflammation of the mucous membrane inside the nose. It can be caused by things like viral or bacterial infections, irritants, and more commonly, allergens. Allergic rhinitis is also called hay fever, and it's typically caused by hay, dust, pollen, animal dander, or mold spores. A high-yield concept to remember is that allergic rhinitis is a type 1 hypersensitivity reaction, which is a type of allergic reaction that starts with exposure to an environmental allergen and is characterized by immunoglobulin E antibody production and mast cell degranulation-releasing mediators like bradykinin and histamine that causes inflammation. This leads to excess fluid buildup in the nasopharynx and facial tissue, causing symptoms. Remember, the typical clinical picture usually consists of nasal congestion, red, itchy, swollen eyes with frequent bouts of sneezing, and in some cases, nose bleeding. These symptoms can begin just minutes after exposure to the allergen and can persist for weeks at a time. Okay, so the most common way to diagnose allergic rhinitis is through skin testing. One type of skin testing is called the patch test, where allergens are applied to small patches and stuck onto the skin. If the skin under a particular patch becomes irritated, it suggests an allergy to that substance. Blood tests might show elevated immunoglobulin E antibody and eosinophil levels, but this is not always reliable. Also, remember that allergic rhinitis may be part of the atopic triad, which also includes atopic dermatitis and asthma. In terms of treatment, the best option is to simply avoid the triggering allergen if possible. Also, remember that if the individual is symptomatic, antihistamine medications like chlorpheniramine and terfenadine can be used to suppress the effect of mast cell degranulation. Let's now discuss sinusitis or rhinosinusitis, which is the inflammation of the mucosal lining of the nasal cavity and paranasal sinuses, especially of the maxillary sinuses. It can be caused by either viruses or bacteria like Streptococcus pneumoniae, Haemophilus influenzae, or Moraxella catarrhalis. It can also be caused by fungi like Aspergillus fumigatus, but a high-yield fact to remember is that fungal sinusitis usually occurs in immunosuppressed people, and it can present with a high-grade fever and dark necrotic ulcers on the face. Now, it might help you to know that the resulting inflammatory process causes increased edema and mucus production, which block the sinus ostium and, consequently, the normal ventilation and drainage of the sinus. Because of this, individuals will present with rhinorrhea or purulent nasal drainage in bacterial sinusitis or clear nasal drainage in viral sinusitis, nasal congestion, facial pain, especially when they lean forward, fever, and conjunctivitis. As the edema and mucus production progresses, it can cause nasal blockage, hyposmia or loss of the sense of smell, as well as tenderness and erythema over the affected sinuses, which is a key clue. As a particularity, infections in sphenoid or ethmoid sinuses may extend to the cavernous sinus and cause cavernous sinus syndrome, which is a condition characterized by multiple cranial nerve palsies. Diagnosis is clinical based on the presenting symptoms. Radiographs and secretion culture are not recommended for evaluation of routine acute sinusitis. Treatment is supportive in case of viral rhinosinusitis. It can encompass adequate rest and hydration, warm facial packs, and steam inhalation. Symptomatic medication might be needed as well, like analgesics and antipyretics for fever or intranasal corticosteroids for congestion. In case of bacterial sinusitis, antibiotics like amoxicillin are added to therapy. As for fungal rhinosinusitis, surgical debridement of the necrotic tissue is often necessary, in addition to antifungal medications like amphotericin B. Next up is epistaxis, or nose bleeding, which can be either anterior or posterior. Anterior epistaxis originates from a plexus of vessels known as the Kieselbach's plexus, located at the anterior part of the nasal septum. Posterior epistaxis originates in the posterior septum overlying the vomer bone, and it involves the sphenopalatine artery, a branch of the maxillary artery. It might help to remember the most common causes of nose bleeding: trauma and drying of the nasal mucosa, and rarely hypertension and coagulation disturbances. Regarding symptoms, bleeding can occur in one or both nares, individuals might have local pain, and in rare instances, nosebleeds may drain posteriorly to cause hemoptysis or hematemesis. Diagnosis is made clinically using a nasal speculum and a bright headlamp or head mirror which can detect if the site is anterior or posterior. However, if a question mentions the bleeding is severe or recurrent and no site is seen, fiber optic endoscopy is necessary to see where the bleeding originates. Treatment in anterior epistaxis consists of pinching the nasal ala together for at least 10 minutes while sitting upright. If this fails, a cotton pledget with a vasoconstrictor like phenylephrine or a topical anesthetic like lidocaine is inserted and the nose is pinched for 10 more minutes. In cases of severe bleeding, the blood vessels can be cauterized with electrocautery or silver nitrate on an applicator stick. For posterior bleeding that's difficult to control, nasal balloons and posterior nasal packs are effective but very uncomfortable. Sometimes, the internal maxillary artery and its branches must be ligated to control the bleeding. Before we move on, we need to discuss another cause of nose bleeding, which is nasopharyngeal angiofibroma. It is a benign but locally aggressive vascular tumor of the nasopharynx that arises from the tissue in the sphenopalatine foramen, an orifice which connects the nasal cavity with the pterygopalatine fossa. It might also be useful to know that it mostly affects adolescent boys, and that it's associated with mutations of the MEN1 gene, which causes multiple endocrine neoplasia type 1. Now, although it is a benign tumor, it is locally invasive and can invade the nose, cheek, and orbit. Because it tends to grow in the back of the nasal cavity, the clinical picture usually consists of one-sided nasal obstruction associated with trouble breathing and profuse epistaxis. On your test, a sign to look for in nasopharyngeal angiofibroma is the antral sign, or Holman-Miller sign, which is the forward bowing of the posterior wall maxilla. Diagnosis is based on CT or MRI, which typically shows non-encapsulated soft tissue mass in the center of the sphenopalatine foramen, which is often widened, deforming the posterior wall of the maxillary antrum. Now, your exams might offer biopsy as an answer choice, but a very high-yield concept here is that this procedure is contraindicated because it might cause extensive bleeding since the tumor is composed of blood vessels without a muscular coat. On the other hand, the treatment is primarily surgical. The tumor is usually excised by external or endoscopic approach. Now, nasopharyngeal carcinoma is the most common cancer originating in the nasopharynx. You'll need to know that it originates in the epithelial cells lining the nasopharynx, and it's usually located in the fossa of Rosenmuller. Regarding causes, a high-yield fact to know is that it's often associated with Epstein-Barr virus infection. Okay, so individuals are initially asymptomatic. Cervical lymphadenopathy is the first sign in many patients. When the tumor grows larger, it can cause epistaxis, nasal obstruction, and conductive hearing loss due to eustachian tube obstruction and the development of a middle ear effusion. Middle ear effusion refers to a buildup of fluid in the space behind the eardrum. Also, keep in mind that diagnosis is confirmed by indirect nasopharyngoscopy, CT or MRI scan of the head and neck, and endoscopic guided biopsy. Another clue is a positive heterophile antibody test which confirms Epstein-Barr infection. Nasopharyngeal carcinoma can be treated by surgery, chemotherapy, or radiotherapy. Another type of cancer pertaining to the pharynx is oropharyngeal carcinoma. Unlike nasopharyngeal carcinoma, it is usually located in the soft palate, palatine tonsillar fossa and pillars, lateral and posterior pharyngeal wall, and base of the tongue. The main causes are thought to be different too. In oropharyngeal carcinoma, tobacco, alcohol abuse, and human papillomavirus infection are the main cause and not Epstein-Barr virus infection. As with nasopharyngeal carcinoma, the individual is initially asymptomatic with cervical lymphadenopathy as an early sign. As the tumor grows, it can cause persistent sore throat and dysphagia. These symptoms are easily overlooked as they are unspecific. Because it can mimic a simple upper respiratory infection, on your exam, make sure you think of oropharyngeal carcinoma if you see any of the risk factors like a long history of smoking, drinking, or HPV infection mentioned along with the previous symptoms. Later in its evolution, the tumor can cause ulceration of the mucosa, oral pain, and weight loss due to the cancer using up a lot of the body's nutrients and because it can cause difficulties feeding. Diagnosis can begin with biopsy if the primary tumor has been detected, or with fine needle aspiration cytology of enlarged lymph nodes. Treatment regimens vary depending on the stage of the cancer, but they usually consist of radiotherapy, chemoradiotherapy, and surgery, which can be either curative or palliative. Moving on, another high-yield oral lesion is oral thrush, aka oral candidiasis, which is a fungal infection of the oral mucosa and the tongue. Typically, oral thrush presents as a scrapable white plaque that looks like cottage cheese. This is caused by the yeast Candida albicans, which can normally be present in low numbers in the oral mucosa. For your exams, some important risk factors for Candida overgrowth include recent antibiotic use, as well as immunosuppression induced by treatment with corticosteroids, chemotherapy, radiation therapy, and diseases like cancer, uncontrolled diabetes mellitus, or HIV infection. Finally, another important risk factor for oral thrush is having a condition that causes xerostomia or dry mouth, such as Sjogren's syndrome. For diagnosis of oral thrush, a sample of the lesion can be scraped off and then analyzed under a microscope, where the most high-yield finding is the presence of pseudohyphae, which is when Candida cells have an elongated shape that looks like long, thin filaments. Oral thrush is treated with nystatin oral suspension by swishing it around the mouth and then swallowing or spitting it out. Now, a very similar oral lesion is hairy leukoplakia, which is associated with the Epstein-Barr virus, or EBV, and typically appears in immunocompromised individuals, such as those with HIV or who received an organ transplant. Now, hairy leukoplakia is a benign, irregular white plaque with hairy appearance that most often appears on the lateral side of the tongue, but can also appear elsewhere in the mouth. Now, the most important clue to help you distinguish it from oral thrush is that hairy leukoplakia can't be scraped off. And another similar oral lesion is leukoplakia, which is also a white plaque that appears on mucous membranes such as the mouth. What's really important to know is that unlike oral thrush and hairy leukoplakia is a precancerous lesion and can evolve into squamous cell carcinoma. Risk factors for the development of oral leukoplakia include smoking or chewing tobacco, heavy alcohol consumption, and HIV infection. Finally, let's go over some high-yield diseases of the salivary glands. The first one, sialadenitis, which refers to inflammation of any of the salivary glands, but most often affects the major ones, which are the parotid, sublingual, and submandibular glands. Sialadenitis presents with pain, swelling, and decreased salivary production. Some high-yield causes include bacterial or viral infection, autoimmune diseases like Sjogren's syndrome, or salivary flow obstruction due to sialolithiasis or salivary stones. Now, sialolithiasis can affect any of the salivary glands, but most cases involve the Wharton duct of the submandibular gland. And that's a high-yield fact. Common causes of sialolithiasis include dehydration, bacterial infection, and salivary gland trauma or injury, and the most characteristic finding is sialadenitis associated with intermittent pain that's worse before and during meals. Treatment of sialolithiasis usually involves NSAIDs to manage the pain, as well as applying warm compresses, followed by gland massage, and sucking on sour candies to help salivary flow and promote stone expulsion. More difficult stones may be removed surgically. Finally, let's go over salivary gland tumors. These are usually benign tumors and most often involve the parotid gland. However, keep in mind that most tumors that affect the submandibular gland are malignant, and that's a high-yield fact. Now, all salivary gland tumors typically present as a lump or swelling that's usually painless, but some key findings that should make you think of malignancy include pain, facial paralysis, or ulceration of the mucosa. In any case, a tissue biopsy is often done to confirm the diagnosis. Now, the most common malignant salivary gland tumor is mucoepidermoid carcinoma. What's important to know is that in histology, mucoepidermoid carcinoma is composed of both squamous cells and mucinous or mucus-secreting cells. On the other hand, the most common salivary gland tumor overall is pleomorphic adenoma, which is a benign tumor that may sometimes become malignant. In histology, pleomorphic adenoma is very variable, but most cases are composed of epithelial and myoepithelial cells mixed with a chondromyxoid stroma, meaning a connective tissue that's made up of cartilage and mucus. Finally, another high-yield salivary gland tumor is Warthin tumor, which is a benign cystic tumor that typically affects smokers. A key rule to remember is that 10% of cases are bilateral, meaning they affect a salivary gland pair on both sides, and 10% are multifocal, meaning they affect more than just one pair of salivary glands. Now, Warthin tumor is also known as papillary cystadenoma lymphomatosum because of its unique histological appearance. Papillary refers to the fact that the epithelium layer folds into the salivary ducts, forming finger-like projections called papillae. Cystadenoma refers to the fact that the ducts fill up with fluid, forming large cysts. Finally, lymphomatosum refers to the fact that the epithelium layer gets infiltrated by lymphocytes, which organize themselves into germinal centers. Alright, as a quick recap, let's go over some nasal, oral, and pharyngeal diseases. A nasal polyp is an overgrowth of the epithelial cells that line the respiratory region, especially in the maxillary and ethmoidal sinuses. Because the polyps obstruct the flow of air and mucus through the nasal cavity, they lead to symptoms like trouble breathing, anosmia, and bouts of fevers and headaches when infection develops. Rhinitis is most commonly due to a type 1 hypersensitivity reaction, but can also be caused by infections. There's inflammation and fluid buildup, which leads to nasal congestion and red, itchy, swollen eyes with frequent bouts of sneezing, and in some cases, nose bleeding. Rhinosinusitis is due to viral, bacterial, or fungal infections that cause inflammation of the mucosal lining of the nasal cavity and paranasal sinuses. Symptoms include rhinorrhea, conjunctivitis, nasal congestion, and hyposmia alongside tender and erythematous sinuses. Epistaxis can be either anterior or posterior, and it's usually due to trauma and drying of the nasal mucosa, hypertension, and coagulation disturbances. Bleeding can occur in one or both nares, and it might associate local pain. Nasopharyngeal angiofibroma is a benign vascular tumor of the nasopharynx that arises in the sphenopalatine foramen. It mostly affects adolescent boys, and that is associated with MEN1. Symptoms include one-sided nasal obstruction, trouble breathing, and profuse epistaxis. The antral sign, or Holman-Miller sign, which is forward bowing of the posterior wall of the maxilla, can be seen on CT scans. Nasopharyngeal carcinoma, most commonly located in the fossa of Rosenmuller, is often associated with Epstein-Barr virus infection. In many patients, the first sign is cervical lymphadenopathy, but as the tumor grows, other symptoms might include epistaxis, nasal obstruction, and conductive hearing loss. On the other hand, oropharyngeal carcinoma is located either at the base of the tongue, soft palate, palatine tonsillar fossa and pillars, or lateral and posterior pharyngeal wall. It is mainly caused by tobacco, alcohol abuse, and human papillomavirus infection, and it leads to symptoms like cervical lymphadenopathy, sore throat, dysphagia, ulceration of the mucosa, and weight loss. Another important oral lesion is oral thrush, which is a scrapable white plaque that's caused by Candida albicans, and risk factors include recent antibiotic use, immunosuppression, and xerostomia. Oral thrush shouldn't be confused with hairy leukoplakia, which is an irregular white plaque with hairy appearance that can't be scraped off and is associated with the Epstein-Barr virus, as well as leukoplakia, which is a precancerous white plaque that can evolve into squamous cell carcinoma and is associated with tobacco, alcohol, and HIV infection. Sialadenitis refers to inflammation of the salivary glands due to infection, autoimmune diseases, or salivary flow obstruction due to sialolithiasis, which most often involves the Wharton duct of the submandibular gland and presents with intermittent pain that's worse before and during meals. Finally, salivary gland tumors are usually benign tumors and most often involve the parotid gland, although most submandibular gland tumors are malignant. All salivary gland tumors present as a painless lump or swelling, while malignant tumors may cause pain, facial paralysis, or ulceration. The most common malignant tumor is mucoepidermoid carcinoma, which is composed of both squamous and mucinous cells. The most common salivary gland tumor overall is pleomorphic adenoma, which is benign but may become malignant and is composed of epithelial and myoepithelial cells mixed with a chondromyxoid stroma. Finally, Wharton tumor, aka papillary cystadenoma lymphomatosum, is a benign cystic tumor that has germinal centers and typically affects smokers. Back to our cases. Andrew came in with progressive difficulties breathing through his nose, the sensation of a foreign body in his nostril, and anosmia. History revealed acetyl salicylic acid sensitivity, whereas the clinical examination and blood tests were normal. His clinical pictures highly suggestive of nasal polyps. Nasal endoscopy, or CT, would confirm the diagnosis. Sarah said she had trouble breathing ever since she was a child, especially during the spring or when she's surrounded by flowers. On examination, she presents nasal congestion and red, itchy, swollen eyes with frequent bouts of sneezing. These symptoms, which appear in the context of allergen exposure, is suggestive of allergic rhinitis. The diagnosis can be confirmed by skin testing.